Thank you, Yvonne and the team. So as you mentioned, I'm Priya. I'm a consultant hematologist, and I work as I'm one of the MPN team at Guy's and St Thomas's in London. And I thought it would be helpful or hopefully useful for you all to give a lecture around myelofibrosis, which is one of the conditions we manage, and I'm sure you all have some experience with this. So it'll be great to hear what you think. So just sort of a very brief introduction to myelofibrosis. So as you may already be aware, it is a excuse me, a myeloproliferative neoplasm, and it is a form of chronic blood cancer with an incidence of 1 to 2 per 100,000 in per annum in the UK. Um, it's got quite unique sort of presentation hallmarks. So common manifestations of this condition include presenting with cytopenia. Sort of a lot of the patients that we see in clinic have been anemic or thrombocytopenic for some time. They may have increasing spleen size, and they also may have significant symptom burden. So typically sort of fever, sweats, weight loss, and have been going on for several months. It'll be for us, they often go to their primary care physician in the community before they come in to see us in the hospital. The specific genetic markers associated with this, so JAK2 is the key driver, but we also see patients who have a CALR mutation and MIPL. JAK2 is generally seen in over 50% of our myelofibrosis patients, whereas CALR and MIPL is probably in around 30 to 40%. Vascular risk is a huge thing. We know that in all myeloproliferative neoplasms, there is an increased risk of thrombosis. And this is particularly seen in those patients who've got the other MPNs, polycythemia vera, or PV, as well as essential thrombocythemia, ET. But actually, myelofibrosis patients can also have quite a high vascular risk. And at the recent sort of ASH meeting in December, they're actually developing new guidelines which are coming out later this year. And they emphasize the importance that actually we shouldn't forget about cardiovascular risk assessment in myelofibrosis patients and ensuring that they're on some sort of antiplatelet therapy, such as aspirin, for example. The main key issue with myelofibrosis is that it's associated with a reduced quality of life. And this has been shown in multiple studies where actually the symptoms associated with this, patients can often find it difficult to, go to work. They find it difficult to do their own general day-to-day living, and it can really be quite burdensome for them. So just talking a little bit more about it. So on the left-hand side, you can see sort of the key symptoms and signs, and this is probably something you may be familiar with. So patients coming with cytopenias, as I mentioned, weight loss, bone pain, which can be quite severe for them, as well as itching and night sweats. And then on the right-hand side, you can see a few images. I'll just make sure, see if I can get my pointer to work. So you can see here the sort of the typical blood film that we see. So leukoerythroblastic features. You've got the bone marrow here, which is showing the streaming and typical of the increased reticulin. And then finally, the imaging here, where you can see sort of the massive spleen size that these patients can have. So when we see our patients in clinic, obviously we assess their symptoms, we do their blood tests, but then you have to think about prognosis, and that's always a question that a lot of patients ask me, particularly those who are quite young, in their sort of 30s, 40s. They want to know, how long have they got? They unfortunately use the internet way too much and Google, so they know everything before they come into the room, and they all think they've got leukemia. So I often have to spend some time talking through this. But the key thing is obviously ultimately they want to know their quality of life, how long they've got, what is the impact for them. And there's so many prognostic scoring systems now. As you can see here, there's a whole host of them for myelofibrosis. So it can be quite challenging to pick which one is applicable to you and how, which one is more importantly applicable to the patient. So what I tend to say if I'm sort of doing teaching, particularly for our junior doctors, is this is what I think is useful. But again, your opinions also matter, and it'll be good to hear what you guys think about this. But for anyone who's newly diagnosed, particularly those with primary myelofibrosis, I personally prefer the DIPS Plus. So this obviously incorporates the blood counts with the symptoms as well. And then anyone with secondary myelofibrosis, you've got the MySIG-PM score, which is very helpful and has been validated in this cohort. Anyone who's quite young, so under the age of 70, we use this molecular score. And this is really, really important because a lot of these patients, you do have to think about transplant, and that's something I'll touch on a little bit later. So this score is very helpful for both primary and secondary myelofibrosis patients. RR6, some people do use it. So for those who are treated with ruxolitinib, and this is a good score to see how they respond to this treatment and their general outcome. And then the MTSS is the transplant score. I will be honest, I don't use this as much, but I know my transplant colleagues do use this when I refer patients on. So using these risk scores are helpful, and these are the sort of figures that really our patients care about is, their overall survival. And generally we know that if this is based on the DIPS plus, so higher risk patients, they have a reduced survival compared to those who are low risk. I think you do have to sometimes be a bit careful about saying this because we've had cases where we've met a patient sort of 10 plus years ago and we've said, right, you've got about 11 years to live. They've come back 11 years later and said, right, so now what? What do I do now? So you have to be quite, these are quite generic figures. But I think in general, what I tend to say to patients is, look, this is all based on lots of people who are probably not your age. They might be a bit older. But the general feeling is that we do know high risk patients do need more aggressive management, and the overall survival is quite low compared to those who are low risk. And the important thing really is trying to monitor them very closely for signs of progression to acute leukemia. So when we talk about the management, I think certainly what we do in our clinical practice is we think about the management goals. So we do our patient assessment, looking at the symptoms, looking at how much this is impacting them in terms of their quality of life. We risk stratify, so you have the whole host of scores. So you pick which score is applicable to the patient and you use that for that patient. Are they transplant eligible? And I think that's always the question in my mind, particularly in those patients under the age of 70. What is the best available therapy out there? And often I will try and give them as many options as I can, and ultimately also think about clinical trials, which we're fortunate to have at Guy's and St. Thomas's. We do have several trials that we can offer to these patients. If they have a big spleen, and how much is it impacting them in terms of their symptoms and pain, their appetite, and cytopenias as well, which are important because they can impact the type of treatment that we choose, and ultimately the disease symptom burden as well. So what I've highlighted here is our British Society of Haematology guidelines. So this was published in 2024, led by Donal McLaunan. And you can see here at the top, obviously you've got your primary or secondary myelofibrosis. The team highlighted the importance of doing a symptom burden score. So we have the MPN-10 score, which you might be familiar with. And this is something we use in our clinical practice. So this score sort of incorporates fever, fatigue, abdominal pain, as well as sort of bone pain and fevers and sweats. We try to document the spleen size as well at every assessment, and we also ensure that the prognostic score is performed. All of our patients are discussed in a multidisciplinary meeting, and ideally all of them should be offered a clinical trial if available. So this is the current guidance. For those with the sort of low risk, it is important, if they're asymptomatic, we do observe them, and we normally say we would observe them every sort of 4 months initially, and then if they're stable, push it out to 6 months. If they're more symptomatic, this can be a little bit of a challenge because then you have to think about, should we be giving them some form of treatment? So in the UK, we don't have access to the JAK inhibitors for this cohort of patients, but we do have access to interferon, which we find can be quite helpful. And particularly also those who are intermediate 1, again, if they're symptomatic, we can offer them interferon or even hydroxycarbamide if possible. For the intermediate 2 and higher risk patients, this group is where you need to think about, are they eligible for transplant or not? If they're eligible for transplant, then yes, they definitely need a JAK inhibitor. You want to maximize your spleen and symptom response and refer early for transplant consideration. If they're not transplant eligible, this is when you look at your different JAK inhibitors, which I'll touch on shortly. And ultimately, you want to be offering them clinical trials options at all stages. So this is the NCCN guidelines, which I also like to include. And I think what I like about this is it does go into a little bit more detail in terms of the cytopenias and the risk stratification. So NCCN, they generally say that they're lower risk, then you look at the symptom burden and then you offer them treatment accordingly. Whereas if they're higher risk, then it really very much depends on the platelet count. So if their platelets are elevated, then and they're not a transplant candidate, then you go through the JAK inhibitors. If they have low platelets and they're not a transplant candidate, again, JAK inhibitors, or you go for transplant quite early on. It should be noted that obviously there are differences. So for us in the UK, we cannot access pacritinib, for example. It's only via clinical trials. And then for dratinib, we can only get that second line. So I think that these guidelines have to be sort of taken quite with caution because not all of us can access all the different lines of therapy that may be available, for example, in the US. In terms of transplantation, so ultimately, and this is something that a lot of sort of the younger patients do want to talk about in the clinic. And there's a lot of things we do have to take into consideration. And I think I like this chart because it kind of goes through the different stages and phases of it. So this is what I tend to break it down with the patient. So pre-transplant, again, age. It's not really it's more about their physiological age, if I'm honest with you. So, you could still have a 50-year-old patient in front of you, but if they have so many comorbidities, if they have, diabetes that's uncontrolled, blood pressure uncontrolled, heart disease, you may be a bit cautious about referring them on for a transplant. Other things, obviously, if their spleen is big, if they're in the chronic phase, what sort of treatments they've been having and how well they've responded to their treatment. So I've had some patients who've been on a JAK inhibitor for a year, 2 years, and their spleen just hasn't really moved very much, and we've been quite limited in options. So, that can play a factor in transplant, in the pre-transplant setting. In the transplant setting, the donor is a big challenge. And, sometimes even if someone is intermediate one risk, if I realize that actually it's going to be quite difficult to find a donor, I would refer them quite early on because they may need an unrelated donor, which may need a global search for them. It's also looking at the conditioning that they might use, as well as their CMV status. Post-transplant, the challenges come with, immunosuppression, weaning them, if they have loss of their chimerism, there's also importance of molecular monitoring, which I'll come to shortly, and whether you need to give them more maintenance therapy. And then finally, if they relapse, would you consider a second transplant? And this is something that, we do debate quite a lot in our MDTs. As I'm sure you may be aware, in the EBMT actually published up-to-date guidelines in 2024 on transplanting myelofibrosis. And generally, as I already mentioned, those with primary or secondary myelofibrosis, intermediate to or high-risk DIPS plus or high-risk MIPS, you need to consider them as candidates. Anyone who has a spleen greater than 5 centimeters below the costal margin or symptoms needs spleen-directed therapy. And ideally, you want to get a matched sibling donor. You could use reduced conditioning, so reduced intensity. It can be quite effective. But the key thing is also driver mutation. So, for example, monitoring the JAK2 mutation sort of on a monthly basis after transplant, because you want to sort of pick up relapse quite early and consider them for donor lymphocyte infusion. So just going into sort of the types of therapies we use, and specifically the JAK inhibitors. So I thought it'd be interesting to include a case here. So this is a patient from my clinic, 50-year-old male, JAK2 positive polycythemia vera, diagnosed some years ago, had an MPN 10 score of 10, which was mainly fatigue, and initially treated with aspirin and venesections. Started to get worsening symptom burden, and you can see here sort of 2025, so sometime later, MPN 10 scores going up. So this emphasizes the importance of monitoring this, and their spleen size is increasing. Blood counts show they've got a hemoglobin of 100, white cell count of 17, platelets of 110, got leukorytoblastic features on the blood film, bone marrow biopsy confirms transformation to post-PVMF, and you use the risk score, MySEC PM is intermediate 2. So it's thinking about what JAK inhibitor would you choose. So For someone like this, again, as I highlighted earlier, the blood counts are important. So the platelets are above 50. The patient clearly has major symptoms and they have a big spleen and they've got a good hemoglobin of around 100. So if it was me seeing this patient in clinic, I would, you could consider a clinical trial, but I guess the first option would be ruxolitinib. Um, so ruxolitinib, as you may be aware already, is a JAK1 and 2 inhibitor. It's been shown to improve spleen volume response, SVR, as well as the symptom score in MF patients in multiple clinical trials. It's also been associated with looking at the JAK2 allele burden, which is definitely of interest in myelofibrosis or any MPN patients at the moment. And in the UK, we use it for intermediate 2 and high risk patients upfront. We usually select this first because we do find it's very effective for patients who've got lots of symptom burdens and big spleens. And the general feeling, and I'm quite conservative, is we slowly titrate up the dosing. So normally in the UK, they would recommend starting at 20 milligrams twice a day. I'm slightly more cautious. I start at sort of 15 BD and then I see how they go on a monthly basis and titrate it up. There's obviously been a number of clinical trials for ruxolitinib or Jakavi. So this is the Comfort 1 and Comfort 2 studies. These were major studies which highlighted the big role of Jakavi and ultimately led to its approval. But there's also Simplify 1. And there's the Landmark survey, which is the real world study, which looked at the impact of Jakavi in terms of quality of life. So, summarizing sort of Comfort 1, Comfort 2. So, these studies looked at sort of ruxolitinib versus best available therapy. They showed that actually it was associated with improvement in the symptom burden and quality of life. And importantly, it was associated with reducing mutant allele burden and transformed into improved survival. And it was approved by the FDA for MF in 2014. Just a little bit more about the COMFORT study. So you can see here on the left-hand side, so ruxolitinib, you can see significant reduction in the spleen compared to best available treatment. And similarly, reduced fibrosis as well. And this was all sustained at sort of 24 months. And ultimately, the most important thing is that there was, improved overall survival. So this is shown by the green line here. For ruxolitinib, there was improved survival compared to the controls, which is shown by the blue line. And this is something that was sustained. So this was, again, shown further here in those with low versus high molecular risk features. So the orange line here is the high molecular risk. And this is with ruxolitinib. And when you compare that to best available therapy, which is the yellow line, ruxolitinib was still able to overcome these adverse features and improve survival rates. However, as with all treatments, there are side effects. And the reason I mentioned the hemoglobin and platelets is because, ruxolitinib is well known to drop the hemoglobin and platelets, particularly in the first 6 to 8 weeks. And generally it does stabilize. The hemoglobin can stabilize after 8 weeks of therapy. But generally what we tend to do is we monitor the bloods every 2 weeks for the first month, and then every 4 weeks, and then 8 weeks. So we sort of relax it down like that. And that's why I'm quite conservative and start to slightly lower dose and titrate up accordingly. We also check their erythropoietin levels because we want to see if we can use that as an adjunct to overcome the anemia. And then the platelets as well, we keep a close watch on those. There is an increased risk of infection, so we do warn all of our patients of this. And we do sort of baseline hepatitis B for all of them. We advise them to be vaccinated, particularly for shingles. So we have an inactive vaccine, the Shingrix vaccine, which we offer in the UK. But we also recommend the influenza vaccine and COVID-19. And then if people don't get the vaccine, we try and offer them acyclovir prophylaxis, particularly if they've had a history of recurrent ulcers or shingles in the past. The other thing to consider is the risk of skin cancers, and this is quite common. And there was a retrospective study that was published by Alex Rampotas last year. So he's based at UCL, and what he did was he did a multi-center UK study which showed that actually there were increased numbers of non-squamous cell carcinomas in patients treated with ruxolitinib. So you do need to be quite careful with this. And I always say to patients, if you're going on holiday, sun factor 50, I do try to avoid it in people who giving ruxolitinib at all, if somebody is, someone who spends a lot of time outdoors in the sunshine or works outdoors quite a lot, or if there's a strong family history of lots and lots of cancers, because that there is a real concern with this. And actually, we have stopped it in people who've had sort of squamous cell carcinomas or melanoma because of the risk associated with this drug. And then finally, ruxolitinib can cause weight gain, which really annoys some of our patients, and I don't blame them. So we do warn them about that they could gain weight, but also their cholesterol levels can go quite high. So we monitor that sort of every 3 months, and we actually recommend treatment for that and actually start it in the clinic for them because we worry about this. I added this Curious 3. So this is a calculator we use to assess the cardiovascular risk in all our patients. So it incorporates sort of age, their weight, their smoking history, and so on. And generally, a score greater than 7.5% suggests a higher risk of cardiovascular events. So we try to calculate this on an annual basis in all of our MPN patients, and then manage it accordingly with their primary care doctors. Then finally, there is a risk of withdrawal syndrome. So, we do tell patients do not suddenly just stop the ruxolitinib. They can become very, very unwell when they stop it. Some of our patients travel from quite far from different hospitals. So what I tend to say to them if they become unwell and they're admitted to a different local hospital, to take the ruxolitinib with them, because it may not be available in the other hospitals they're in. So at least they don't risk missing any doses. And we generally don't stop it, even in people who are having surgery or even if they have infection, we will try and continue the ruxolitinib through this. So, as I mentioned already, ruxolitinib can be associated with dropping the hemoglobin. I mean, you can get anemia as well in myelofibrosis patients. And the British guidelines did try to address this. So, obviously, if you do have anemia in these patients, you try to exclude common things are common. So you try to exclude bleeding, hematinic deficiency, hemolysis. You look at the EPO level. If there's an inadequate level, then we try erythropoietin. So we will start them on a weekly dosing, and we'll see their response at 3 months. And if they're responding well, we continue. If not, we try to stop it. If they have good EPO levels, so for us it's more than 500 units per liter, then we would then consider danazol. I will be honest, we don't really use this a lot anymore. But there's 1 or 2 cases that we're using at the moment. So we use danazol to see, and that can be quite helpful for patients who, we're very limited in giving them JAK inhibitors because of anemia, because it can also help to reduce the spleen size as well. But there are other alternative options, which I'll talk about shortly. And this is just a further, I thought this was quite helpful. So this was published in a couple of years ago, again, looking at sort of anemia diagnosis and workup, and just again highlighting, not just attributing everything to the myelofibrosis or to the JAK inhibitors, but excluding other things as well. So, looking at the hematinics as well. Checking for hemolysis. So we've had 1 or 2 cases where patients have developed autoimmune hemolysis, who also have myelofibrosis. So that's been quite tricky for us. And then we've also had, excluding other hemoglobinopathies as well. The key thing is bleeding. So particularly for patients who've got really, really big spleens, they're high risk of developing portal hypertension and having esophageal varices. So particularly if they have very big spleens, I would refer them quite early on to our gastro doctors for them to do an endoscopy to see if there's any varices that need banding. So that's just something to consider. So the other thing is obviously identifying those people who are not doing well on ruxolitinib, and this is where the RR6 score, which I mentioned earlier, comes into play. So generally what I tend to do is I'll do a baseline assessment of their spleen, their blood counts at baseline, and then I'll repeat it at 6 months. And ideally you want to see the spleen reducing. So for example, if it's at 20 centimeters, you ideally want it coming down sort of 15 centimeters or even less than that. And if they're not, then they could potentially have some form of resistance. The other issues can be also intolerance. So, for example, if they have the skin cancers, if they're getting severe side effects, if their platelets are dropping, if they're needing transfusions, then it may come a time to stop it. And then the other concern is obviously if their, blasts are going up or if their spleen size is increasing. What I will say is it's so important that they're on a good dosing of ruxolitinib. The number of times we've seen patients where they're only having sort of 5 milligrams twice a day, that's not going to do anything for their condition. So the minimum dosing I would say is acceptable is probably 10 milligrams twice a day. Below that, it's not going to be very effective at all. And if they've been having this dosing and they're still not responding, then you can say they failed and then you move them on, which is why I'm bringing up the next case. So the next case is actually another lovely gentleman I look after who is a primary myelofibrosis diagnosed in 2017, had a very significant MTN score and actually was started at that point on ruxolitinib. And he was titrated up, he had good symptom control, but over time was becoming more anemic. And you can see here his hemoglobin slowly drifting down, and we checked everything, not bleeding, hematinics, EPO, all okay, not really much else we could do. And we tried dose reducing his ruxolitinib, but then the spleen started increasing. So you're kind of in the situation where you're trying to manage the blood counts, but the spleen is now no longer under control. So at this point, we switched him to momelotinib after 7 months of treatment. So momelotinib is another new player. So it's a JAK inhibitor, but also an activin A receptor inhibitor. And the key thing about momelotinib is it's, through the activin A, it helps to increase hemoglobin levels so it can counteract the anemia that we see. And it was, showed demonstrated efficacy in both Simplify 1-2 studies as well as Momentum. And for us in the UK, it was approved for intermediate to and high risk MF patients with anemia and splenomegaly. This is people who are JAK inhibitor naive, so we could give it up front, but we can also give it to people who have failed after ruxolitinib as well. So this is just, again, the study that, helped us to prove that momelotinib is effective. So it was shown in Simplify 1. So Simplify 1 compared momelotinib versus ruxolitinib, and this is in JAK naive patients. And overall, what happened was there was transfusion independence demonstrated, and actually this correlated well with survival, and this is shown by the survival curves here. So people who responded well to momelotinib and had a transfusion independence had better survival rates compared to those who did not become transfusion independent. And the key thing about momelotinib versus ruxolitinib is it showed sort of non-inferiority in terms of symptom control and spleen response as well. And similar things, sorry, it's quite small here, but essentially it shows that, transfusion independence overall was associated with improved survival. And this was at week 24 in our MF patients. And furthermore, the spleen volume response, as I mentioned, there was non-inferiority between momelotinib and rux. So effectively, they're as equal as each other in terms of managing the spleen. But the key thing about momelotinib is it helps to improve hemoglobin levels in these patients. Another JAK inhibitor, which is fedratinib. So we don't use this as much, I would say, if I'm honest, just because we have ruxolitinib, we have momelotinib. So I think fedratinib has kind of fallen down in our pathway. But it is an effective drug. It inhibits JAK2 and FLT3 with the Jakarta study, Jakarta and Jakarta 2. Showed that, in patients both naive as well as JAK inhibitor treated patients, it's still associated with good spleen response, and it is used for intermediate to and high risk patients. However, there are adverse effects. So the biggest concern, obviously, the big safety alert that came with this drug was the Wernicke's encephalopathy. So patients were very, very, very unwell with this. So all of our patients have thiamine levels checked. And especially, I think those who are particularly cachectic, who've lost lots of weight, who've been very, very unwell, I would be quite reluctant to use fedratinib in these patients. So I would try to avoid it if I can. Also, the GI toxicity. So our patients do have a lot of nausea and vomiting with this. You can try and counteract it by taking the fedratinib sort of with a high-fat meal, lots and lots of anti-sickness tablets in order to counteract it. But it can be quite a challenge. And also the key thing is it's associated with anemia and thrombocytopenia, as I mentioned already. So, to counteract the sickness, try and have it in the evening meal with a high-fat meal. Apparently that helps. And always check baseline thiamine levels. And in our UK, so I put here blue text. So this is basically the annoying paperwork we have to do to try and get access to this drug. But it is second line, but if I'm honest, we're not using it as much. So I thought it would be also helpful just to talk about sort of the new stuff that's coming out. This is a very, very complicated chart, but essentially it's showing that there's so many new drugs coming out there. So there's obviously your JAK inhibitors, there's the CALR therapy. So this is very exciting. So this is for our CALR mutated patients. So we have sort of bispecific, so immunotherapies that are coming out, as well as vaccines as well. So really, really exciting. There's these epigenetic regulators, as well as things targeting specifically fibrosis and microenvironment. And there's also immunotherapies as well. And this is summarizing this very, very busy slide. But you can see here there's sort of lots and lots of, you've got things being combined with ruxolitinib. So we've got sort of new sort of and cell cycle checkpoint inhibitors, so metelstat, which I'll come to a bit shortly. There's new TKIs that are coming through. There's next generation JAK inhibitors. There's actually new JAK inhibitors that are being developed, which are much, much more highly selective. There's specific ones targeting the apoptosis pathway. Obviously, immunomodulatory drugs. So we're trying to, utilize interferons, which are already available, and seeing if the combination of ruxolitinib is effective. And then you've also got the epigenetic inhibitors. So here I'm just sort of including some of the stuff that was discussed at ASH in December, quite exciting data. So this was the bomedemstat, which is an LSD1 inhibitor, so another epigenetic inhibitor. And essentially, this has been shown to be highly effective when combined with ruxolitinib, and it's well tolerated and associated with good responses. There's not just in myelofibrosis, but also in polycythemia vera. So quite an exciting new drug. There's also the BET inhibitors, so pelabresib. So this has been shown to be quite effective when combined with ruxolitinib, and this was demonstrated in the Manifest-2 study. So this, pelabresib with Rux versus placebo and Rux. And generally there was a higher spleen volume response, and with only a quite low discontinuation rate. But there was obviously this early signal of increased leukemia rates that were observed in both treatment arms, but this was only quite early on. And then beyond 12 months, there wasn't any difference and there wasn't any increased concern after this. So I would say this is quite exciting, but definitely there's a lot of close monitoring required for these patients. Then we've got the PROMISE study. So this is currently open at Guy's Hospital. So this is offered to intermediate to high-risk MF patients who are already on ruxolitinib, and they're not having a great response, as I mentioned before. Spleen's not responding very well, symptoms not going down. So you can add in this new BET inhibitor. And again, this has been shown to sort of improve response rates, reduce the spleen size, and it can reduce the symptom burden. So it's quite an exciting combination. And then, other combination studies. So there's Keros, which was looking at a new drug combined with, again, ruxolitinib, and this was shown to improve hemoglobin levels. So it's basically, similar to momelotinib, but it's a combination strategy. So it could be an alternative option if people don't get along with momelotinib. And then there's the PIM1 kinase, which is another combination study. So again, combined with momelotinib itself. And again, was shown to improve response rates in those patients who weren't doing well on momelotinib alone. There's nivolumab, which you may be familiar with. So this is more from the sort of the lymphoma world, isn't it, really? So it's like PD-L1 inhibitors. So I was a bit intrigued by how they combine this with fedratinib, which is a very, very toxic drug, but somehow patients seem to tolerate it. I'm not quite sure how. But it was effective, and they did say that actually, 90% of patients had adverse events, but it was only grade 1 to 2. Apparently, they didn't really discontinue it. I'm still a bit dubious about this one, but interesting data. And then this is Fedora, which is actually, I think this is much more a realistic combination. This is fedratinib with veropegylated interferon or Besremi. So again, this is one that we also have open at Guy's Hospital. This combination was shown to be well tolerated, improved symptom scores, and spleen size. And I think what I liked about this is the fact that the two treatments are already out there. So essentially, you're combining two things that are out there that we could potentially access. So this is quite interesting. So watch this space. But I think there's a lot of exciting stuff coming up in the myelofibrosis world. However, not forgetting that this is currently what we are working with. And so, in the UK, these are the drugs that we have access to that are approved. And then obviously pacritinib, unfortunately, is only available through clinical trials. And I think if we were to sort of position this where we're going, so first line, if they're JAK inhibitor naive, again, I think the platelets are really, really important. The platelets less than 50, use pacritinib if you can access it. Otherwise, you go for ruxolitinib, fedratinib. And then momelotinib is very helpful, particularly those who are anemic, but also if they have platelets less than 50. So just something to bear in mind. And then if they fail ruxolitinib, then you try and basically go to these different combinations, but ultimately you want to think about clinical trials. And then finally, just this is sort of summary of all the different studies that have been involved. So obviously the Comfort 1 and 2 for ruxolitinib, Jakarta and Freedom studies for fedratinib, Persist studies for pacritinib, and then momelotinib, you've got Simplify and Momentum. And then a final summary is obviously not forgetting that we have to assess the patients overall. You have to look at their performance status, cardiovascular risk is important, as well as their comorbidities, highlighting the risk stratification. So, the numerous scores we have available to us, but picking which ones are actually really applicable to our patients. If they're transplant eligible, refer early, is what I would say. And which available therapy is basically what you have available to you. But always think about clinical trials if that's an option. Spleen is important, so symptoms and spleen and cytopenia. So the best way to think about this is always when you see the patient in front of you, what is the main problem? If it's the spleen that's the problem, then you want to give a JAK inhibitor to try and reduce this. If the cytopenias are an issue, then you want to try and address that. Make sure you don't forget sort of common things are common, like hematinic deficiency, and then picking a JAK inhibitor that's not going to worsen this. And if the symptom burden is high, again, picking the JAK inhibitor, that's going to be most effective at reducing this. So I think the final sort of conclusions is that, we have so many new JAK inhibitor options out there, but there are new kids on the block that are coming through. There's a new JAK inhibitor that's coming out this year in clinical studies, which is quite exciting. So watch this space. Obviously, transplant improves outcomes, but there is a transplant-related mortality rate that's associated with this. So it's not an easy decision to make. So I think patients need to be told this. And they need to be aware that, this is not a decision we come to very likely. But if you do think they will warrant transplant, then refer early. Combined studies are probably the way we are moving towards. So, we've got CPI. Navitoclax sadly was removed from the studies, which is why I didn't discuss this too much. But I think ultimately these are showing that actually combining a JAK inhibitor with another drug may be the way we are going now in terms of maximizing response in our patients. We shouldn't forget to assess cardiovascular risk, but also thinking about other conditions such as skin cancers, kidney and liver disease as well. Any patient who gets infections, particularly on ruxolitinib, manage it quite aggressively. Always try and offer them prophylaxis with vaccinations. And I'm ever optimistic of more drugs that are in development in the future. So watch this space. And that's my final slide. So thank you very much.
Thank you, Priya. That was really interesting. I know that Josh has some questions, and there's also one in the chat from Dr. Sahar who says, I would like to ask, how do we manage hemolysis conditions with myelofibrosis? Do you have any other questions, people? Please put up your hand. But yeah.
Yes, of course. So the hemolysis, so actually we work them up as we normally do for any hemolysis. So the patient in question I was talking about is so when they were actually DAP positive, and we did a full workup, did a bone marrow, did a full CT scan, sent everything. We didn't find an obvious cause, so we actually started them on steroids. And they responded really, really well to that. And then we slowly weaned them off the steroids, and the patient's actually done pretty well off treatment and has been moved back onto a JAK inhibitor. So we think it was just a trigger. So I would probably say that's how we normally manage it with the MPN patients. I hope that helps them.
Thank you. Josh, do you want to ask your question?
Yeah, it's thanks, Priya. That was fantastic. I just remember myelofibrosis being much more straightforward than that. But yeah, gosh, there's so much going on. It was more a question for my Zambian colleagues, really, around the diagnostic end of this, because uh, I mean, from my limited experience in Zambia, there are an awful lot of people with large spleens, anemia, and fatigue. And I'm sure if you did bone marrows on all of them, you would find quite a lot of fibrosis, most of which was reactive. And if you have relatively limited access to molecular diagnostics, how do you go about making this as a diagnosis in the sarca? I'd just be really interested to understand how you go about this, really.
Okay, I can answer something, and we have our colleague Dr. Coad also available. He can add. But we start first of all with the history. We start with the morphology, like we consider the teardrop. Sometimes we consider the dry tap for the aspirate, and the biopsy also having the fibrosis. Um, most of our patients, they don't manage to do the JAK2 mutation because of the financial issues. But also we are very limited for management and treatment and the availability of the JAK2 mutation target therapy. Um, so it's tricky for us, and sometimes it takes a long time for us to conclude the diagnosis of myelofibrosis. Thank you.
Yeah, that's very really illuminating. Is there much of a difference in pattern in terms of marrow reactive fibrosis as opposed to um, primary myelofibrosis, and is that distinguishable? Anyone?
I wasn't sure. Sahar, you probably have no more experience than me, so I'll let you go first.
We could say the reactive fibrosis most of the time is associated with other malignancies. So we notice this very much for the bone marrow with lymphoma patients or other cases of the solid tumor with bone marrow metastasis. We consider it more as a reactive fibrosis. Thank you.
No, thank you. I think also it depends. I think sometimes the megakaryocytes on the bone marrow, they're but much more tied to clusters, I think, for sort of myelofibrosis, whereas I don't think you get that as much with autoimmune fibrosis, from my very limited experience, but that's what I have seen as well. So that can also help to sort of distinguish the two. And as you say, Sahar, like when there's other clear malignancies involved, that can help to sort of distinguish them.
Sorry, I feel like I'm hogging the questions, but
No, please.
so if if in this, but I suppose I'm trying to stimulate a discussion about it really. So if in the situation where you're fairly certain on the fibrotic pattern and that you've got somebody with myelofibrosis, even better if you've managed to get a molecular test that sort of supports that. Dr. Zahar, you said that your therapeutic options were limited. So a question for Priya, really, in that sort of resource limited environment, kind of how would would you use more interferon?
I would, yeah.
Ruxolitinib, I imagine is relative can be made available, I guess, but I'd have to see
Yeah.
what Dr. Sahara and Dr. Kaur said, but.
Yeah, it'd be interesting to see what you guys say. But yeah, if I was in that situation, I would probably pick interferon more than the other drugs, just because we know that interferon has been shown to sort of reduce the fibrosis and reticulin. There's a lot of data now out there for interferon. Hydroxycarbamide is not, is fine as well. Probably not as I would say both of those drugs are not as quick at reducing the spleen size. So I guess that's something we have to take into consideration. But I can't imagine. Yeah, I can imagine the challenges and stuff of accessing JAK inhibitors. So those are two very valid options. But again, personally, I would go for interferon. That's my preference, I would say.
There's a question in the chat that's quite long. Dr. Sahar, before we move to that, Dr. Sahar, what do you treat them with?
Mainly with hydroxyurea and supportive medication, blood transfusion and platelets. This is what we have because even interferon is not much available here.
Mm.
Yeah.
What about the danazol option? I saw that came up, and that's I imagine a relatively cheap drug.
Danazol is definitely an option, and also I think we are using it still. Probably in a couple of our patients, we've had some tricky patients where we can't give JAK inhibitors or anything else, and it's a slow drug. It takes time to work, so more than 6 months. And obviously you have to be careful in men who've got a history of prostate cancer, so you have to avoid it in that situation. But it can be quite effective at improving hemoglobin and reducing spleen size. The other option is obviously, we obviously used to use things like thalidomide with steroids, so that can be, thalidomide with prednisolone. So I don't know how easily accessible that is, but that's something else, I guess, that could be offered in some patients, and that's been shown to sort of reduce the spleen size as well and help with the blood counts.
So there's this long. Do you see the question
I
from
do, yeah.
that's Dr. Koa? I'm not going to read it out.
No, thank you. I would definitely shall I read it out to everybody just in case they can't see in the chat? But it's a 50-year-old patient on ruxolitinib for 18 months, still has anemia, leukocytosis, low platelets, big spleen, being transfused and being worked up for a transplant. Should we pursue this route or try an alternative JAK2 inhibitor? I think I would try an alternative JAK2 inhibitor if you can get access to it. So I think, if sorry to speak from a UK perspective, but obviously if they're anemic, you would try and offer EPO if you could, if they are able to respond to that with the ruxolitinib to try and help. But I appreciate it's challenging with the platelets. But I think, an alternative JAK2 inhibitor like momelotinib might be a good option to consider in this case. And sometimes what we have done is people who've got leukocytosis, we've given sort of a JAK inhibitor combined with hydroxycarbamide. So because the hydroxycarbamide can help to reduce the white cells, and then we use the momelotinib to boost up the hemoglobin and reduce the spleen. And so I hope that answers your question, Dr. Koa.
Can you speak, Dr. Koa? Did that? I don't see him on the Okay. Is there any other questions from anyone? No. Well, thank you very much. That was fascinating. There is a link to the feedback call. I enjoyed it very much as well. And as I said earlier, it's recorded. Once editing is completed, it will be available on the website page. Dr. Sahar has the link.